Well, thank you very much, everyone. We're the Torbay Paediatric team, and I'm Phil Reilly, the Paediatric Diabetes Lead, and I've come here with my colleagues, Alison White, a Specialist Diabetes Nurse, and Liz Wardle, our Specialist Dietitian. And we've come here today really to describe to you our experience, the journey that we've begun together, the challenges that we've had, and also to celebrate our achievements. And in the spirit of learning and sharing that we've been talking about throughout today, I hope that our experience resonates with some of you in the audience, and that you take away from it something from what we have done and experienced. So this is our beginning. This was in 2013-14. We were an outlier. And we felt really strongly that if we didn't come here today to tell you about us, what we've done, what we've experienced, our challenges and where we're going, we would remain as anonymous and as demoralized as our code, PZ152. I find this slide very powerful, both personally and from a team perspective. It takes as read that there isn't one person in this room who doesn't really care about the care that they're giving and their young people and children and families. That's taken as read. So if you can imagine how it feels to see this and know that this is your centre, you will understand where from a personal level we're coming from. But something else it gives us, which is really powerful, is because of this we can really empathise with those children and young people who come to our clinic who do not have the best blood glucose control, who do not have the stellar HbA1c, who are the ones in red on the DIASCEND. And we have used this to create our ethos, to start our new beginnings, to realise that we're starting this journey at the very same place that they are. And that's been quite powerful for us. And the second thing is, we are a young team. We picked this year because shortly after this, we became fully staffed. And there's nothing like this as a bombshell to build your foundations from. So we really felt that we had an excellent opportunity to have that debate amongst us, an urgent debate about where we were going from here. And through the next slides, I really want to share with you that journey. So we're talking about a foundation. We haven't even got to the first floor yet. But I do believe our foundation is firm. And these are the things that we have, these are the three principles that we felt starting out that were important to us. We needed to start this journey together. If you remember the last slide, and our young people, many of whom have really high HbA1cs, we needed to start this journey together. And our ethos needed to be engaging those just as much as those newly diagnosed who had really good HbA1cs. And there was a narrative nationally that what you need to do to get good results is to focus your energy on those who are able to obtain good results. And as a team, we felt that just wasn't us. That wasn't being true to where we'd come from, and it wasn't the direction that we wanted to take. So we have tried to walk this journey from the beginning with our young people, whether they're doing well or not. The second really important thing that we thought as a team was getting to know one another. And that meant really getting to know each other as a team. I expect the rest of the team think they've got to know me rather too well. But, you know, we got to know each other's foibles, we got to know each other's strengths, each other's weaknesses. You know, some of our away days were like televised admissions from the House of Commons. You know, there was huge debate, but we've really built on that, and we trust each other. And we know now that if there's a newly diagnosed young person up on the ward, or whether there's someone coming in DKA, the message will be the same, whoever goes to see them. So I think that's been really important. But also equally important is the fact that we have really taken time to get to know our young people and our families. We've made an emphasis to know what their hobbies are, what their sports are, what they like to do outside of that clinic setting. And we centred the debate around what matters to them. And the first 5 minutes, actually over time, has become more and more interesting because we're asking them, about how their interests have developed from last time, how's their team doing, how their interests going. So I think that's been really important. And the third thing was mentioned by Chizo in the last talk, was setting our expectations high. But crucially, that's not just for those who are doing really well. That's for everyone, and as a team, and through the examples you're going to hear from my colleagues, we've really tried to do that with each and every one of our families and with ourselves, so that wherever we are on that scale, the important thing is that we keep improving. So without further ado, I'm going to hand you over to Liz.
Thanks, Phil. I'm going to focus on just part of our service, which we feel we have made great changes in, and that we're really quite proud of as well. And it's really comforting to hear with the talks preceding us as well that we are doing a lot of the right things, and we are also doing a lot of the same things as other centres as well. So what does our transition service look like? So it may look similar to yours, or there may be some differences as well. We have 2 adult physicians, and as Phil says, we are a relatively new team coming together, so we needed to reset the scene for transition as well and find out how this was going to work for our service. We have, with best practice tariff, we have 1.2 whole-time equivalent dietitians, and we decided to split this into 3, so we have 3 different dietitians, and we're very fortunate to have 2 of these dietitians who also work in the adult team, and we feel this is a really excellent link to the adult service as well, and it's 2 more faces who are familiar and go through that transition with the young people as well. So that's worked really well for us. We also looked at our clinic setting. In the past, we had models where the young person would come to a transition clinic, and there would be the whole of the adult service there, the whole of the paediatric team there. And you can only imagine how uncomfortable that feels for a young person sitting in front of that huge panel. So we listened to what young people said, and we felt that the best solution for us, and logistically as well, was to hold out our transition clinics in the paediatric setting, and the 2 adult physicians come and join us. We're also fortunate to have 2 sites that we can offer as well across our patch, and we can also offer later appointments for young people who are still at school or college or at work to help facilitate that for them. We're also very lucky to have an excellent coordinator in our team, and she is able to arrange the appointments so that in the first year of transition, the young people will have 1 appointment with our adult team. The second year, they'll have 2, then 3 and 4, and so on until they're ready to move across to the adult service. And we actively use the Ready, Steady, Go system, and we're all responsible for filling out the paperwork for this. And this is working really well in our service. We have a monthly transition clinic, which our coordinator helps organise. And our patients are able to stay with our service up to the age of 19, and then when they are choosing when they're ready to go. But we have found in our experience the majority of patients have chosen to stay up to 19, some even coming back from university to have a final appointment with us. Okay, so how have we actually strengthened the links then with our adult service? So the first thing we started with was to have a transition away day where we brought together both teams, and this was enormously helpful. And part of our aim of this day, or the initial day anyway, was to start really busting the myths and the misunderstandings between the adult team and the paediatric services. And there was a bit of a feeling that perhaps the paediatric team was warm and fluffy and really nice, and maybe the adult service was a little bit different and a little bit harder. But there was real passion in the room when we had that away day, and it was absolutely clear that the paediatric team and the adult team alike care hugely about all of their patients. So there was no difference there whatsoever. Everyone was really passionate about it. But for us, it was really interesting because the adult team had a view of the paediatric service and really asked us, why are you so regimented about it then? Why do you have to see your patients so often? And it became apparent they didn't really have a full appreciation of the audit that we were doing. And now we have them on board and they're actually helping us to complete the audit. So yes, that was a really important phase in our development. And from that, we were able to then develop more consistency between our teams because there were big differences between, for example, advice on giving insulin with snacks. That was really different between our teams, so we've smoothed that out now. So that's just one example. So we're all speaking the same language, giving the same messages. We've also learnt a huge amount from each other as well, from sitting in each other's clinics, learning each other's language and skill sets and tools as well. And this has enabled us to really trust each other, whether the young people are with the PEDS team or the adults team. And this is strengthened further with monthly meetings with the adult team as well. And we're also really proud that our adult physicians also join us to attend our Southwest Paediatric Diabetes Network meetings, and we attend as one team. And we're really proud of that. Okay, so other things that we've done differently. Some of this you will have heard in some of the talks already, but one that really sticks out is really setting the expectations very high. And feedback from parents here has been interesting. We start carb counting right from day one on the ward, and we've invested time to train our ward staff to enable them to support families in doing this, and it's been really successful. And this is for all families, so we also have quite a large proportion of deprivation in our area as well, but we expect the same from every family. And I would echo what Cheese was saying about just adjusting your tools and skills to suit the family, but the expectation is still the same, it's still high. We're also really proud of our new pathway for newly diagnosed patient, which has helped facilitate this too. We're also lucky to have a psychologist as part of best practice tariff, but one of the particular things that she brings to the team as well is having regular psychology consultations as well, and that helps us particularly with the really tricky patients. So as Phil said, we've really grown as a team together, and with the number of staff we have now, we can offer much more flexibility. We can use different members of the team at different times for different children and young people, particularly when things are not going well or they're not gelling with a particular member of staff. We've also enhanced our communication skills as well. We use a lot of motivational interviewing and behaviour change skills, particularly with the children and young people of finding things tough or a bit stuck as well. So the language we're using in clinic now is not how's your diabetes going or how are things with your diabetes, but more how are you today? What actually matters to you as a person? And is your diabetes stopping you doing anything? And if it is, what can we do to work with you and help with you to get around that? So I just got a quick patient example, just a quick patient story, just to try and illustrate some of this. So this is a young girl who was diagnosed when she was at primary school. And she was living with her father and older sister. Her mother lived away in London. And she went through a very difficult stage when she transitioned to secondary school. Her behaviour was very challenging. She was involved in smoking, drugs. Her eating behaviour was very erratic as well. This caused her to move schools several times. Then her father became very unwell and she had to go into foster care, and schooling was so difficult that she was under a pupil referral unit. So a very tricky time. And for us as a team, she was non-compliant with her treatment. And I recall one particular clinic appointment where we were probably a bit prescriptive in style, and she reacted really badly to this, ended in tears, running out of the consultation room, and for quite a while she refused to come in and sit with a paediatrician and engage at clinic consultations. So it made it difficult for her to reach out to. So what did we do with her then, or to help her? So we used a flexible approach, and we trusted each other as a team to provide really consistent care to her. And I think one of the things that sticks out for me is we absolutely stuck with her through this period, through thick and thin, really. We didn't give up on her. We did also acknowledge our own failings as well. We showed her that we're human too. We don't always get it exactly right, and that we were willing to adapt to her as well. So we met on her own terms, and in clinics, she would come and see a dietitian or a nurse, but refused to see our consultants at that time to help her start to feel more comfortable again, and her dad would go in and see one of the consultants. We also allowed her to, or encouraged her to set her own small targets as well, and we knew that she reacted really positively to praise, so we would try to find at least one small thing with every consultation we had with her. And one that springs to mind is an occasion where she was going into DKA, and she took responsibility to call the ambulance herself, so we gave her plenty of praise for that. So even positive praise in not so good situations. So we continue to do that. So we seem to be coming out the other end now, luckily, and she came to clinic recently, looked fantastic in appearance, really looking after herself again, cleaned things up. She's settled in school. She's really engaging in her GCSE studies, and is now really willing to take on more responsibility for her diabetes with the full support of her dad. And she's engaging much, much better with our team, and very happy to come in and see the consultants and have a chat with us now. So we've stuck with her through thick and thin. So what's next for our team? There are lots of things in the pipeline, but I just wanted to say a big thank you to our local Southwest network team, because we feel we've gained an awful lot from the network, not only from the wider network meetings, but also in our own specialities as well. We've learnt huge amounts, so we feel we're on this journey together. So a few things in the pipeline. One is, I just wanted to mention, was cook and eat sessions in schools, and I'd like to give credit to the dietitian at Royal Devon and Exeter for this, and she's been happy to share resources with us to get us going with that. We're also further developing our education curriculum as well, so there's lots more in the pipeline. So I think we are still on the journey. We're learning from everybody else too, and happy to share as well. And I think you'll see in Phil's further slides that our improvement is validated by our audit numbers. Thank you. I'm going to pass over to Alison now.
I'll try and be quick. So standing here today, I have to be honest to say that I have very mixed feelings about presenting. I spent a lot of time preparing a presentation, PowerPoints and slides, but increasingly felt more and more that it didn't really reflect what I wanted to get across to you today. I didn't want you sitting out there going, yes, so what, we're doing that. So I want to speak to you from the heart, and forgive me for reading because I had to write it down to say you. But I want to tell you how it is to be a team seated at the wrong end of the National Audit results tables. It's fair to say the National Audit and I are not the best of friends. I have a love-hate relationship with it, as I expect you all do. As a team, we've entered data into it from the very early days, and when I was working single-handedly, it took a vast amount of time and resource to collate and enter the data, and I saw it as taking precious time away from patient care. Year on year, as the results were released, they plunged me, and latterly my team too, into a sort of gloomy Eeyore-like state, where for a time we just feel that yet again all our efforts and work had been in vain and that we were still failing. At regional meetings, our results have been highlighted and we've been held up as outliers. But I don't want this to come across as sour grapes or making excuses. What I want to demonstrate is how the audit has benefited our service, and at the same time demonstrate what the audit is failing to capture, and how for our families it's not all about numbers, but how we work with individuals where they're at and how we're able to make a difference by supporting and empowering them. So the national audit's been hugely beneficial in conjunction with the best practice tariff and DQuins in helping us to get the full team that we've got today, that we can drive our service forward. 13 years ago, when I came into post, our team looked very different, with just one nurse and one paediatrician, no dedicated dietetic or psychology time. And as Phil said, it took till 2013 for things to start to change and our team to finally start coming together, which it finally did in 2015. So my hate side of the relationship with the National Audit mostly relates to the information it fails to record, and it's been really encouraging doing that piece of work this morning because I think it actually covers a lot of my points. We look after 140 children and young people across a wide geographical area, and I feel quite significant the audit doesn't capture the disproportionate number of these who are either currently known to or have been known to children's services or have additional needs. This actually equates to a little over 15% of our caseload, who are either on child protection plans or have been on child protection plans or are in need or have had early intervention, or those with severe learning disabilities, those in foster care, which for one of our young ladies, that was 10 foster placements. Or children with severe learning mental health issues, which require inpatient admission. In one case, we had one girl in for over a year. That 15% is a sizable proportion, and it's a real challenge to achieving low HbA1c levels. Nor does it capture things like the work that's been done with one severely autistic boy who's had numerous visits to the retinal screening department to help him become familiar with it and desensitise him to his fears. In terms of the audit, he's recorded as a missed care process because actually, as yet, we haven't succeeded in getting him screened. Previously, staffing levels only allowed us to firefight dealing with problems as they arose, but now with a full team, with technological advances like DIASEND, we're able to work far more effectively, improving patient care and empowering families through education and ongoing, consistent and persistent support. We now intensively support families who are struggling more and in a more timely manner, which allows us to prevent the fires in the first place. So I just wanted to share a couple of very brief examples as to how our team's now able to work differently and is making a difference to the lives of families, but who in terms of the audit won't necessarily show up as big improvement. One family in particular I think illustrates much of what I've spoken of so far, demonstrating that we're working differently and how the expectations of not only our team but of our families has changed, whilst at the same time showing what is not possible to capture. This family have 5 sons. 3 of them have type 1 diabetes. They live in a deprived area, have a history of domestic violence within the home, drug use and parental illiteracy. They're a family for whom learning doesn't come easily. The eldest son was 10 when he was diagnosed and when I was the only PDSM. Initially things seemed to go okay, but they deteriorated rapidly. He began refusing to test his blood glucose levels and to inject his insulin. Referrals were made to children's services, children were put on a plan, the parents attended parenting courses. As part of the plan, I visited weekly, but I couldn't sustain this on my own for long, partly due to pressures and demands from the rest of the caseload, but also because each visit felt like Groundhog Day. And I wasn't making any difference. And I put my hands up to say that I stopped the visits as emotionally I'd given all I could and I felt I was achieving nothing. I gave up on that young man. I let him down. Fast forward to the last couple of years, though, and 2 of his younger brothers have been diagnosed. He's now under adult services and still not engaging, but with a new team ethos and greater expectations, we've determined as a team that these 2 will not be allowed to follow suit. Right from diagnosis, education was much more structured and expectations were high, but the social circumstances have remained unchanged and a similar patterns begun to emerge. This time, however, with increased resources and determination that we're not going to give up on this family, the team have badgered Children's Services to take the risks of poor diabetes control seriously and sought support from them. And since July last year, the team have worked closely with the family, often making little or no obvious progress, but not letting that put us off. The boys are visited either by 1 or often 2 members of the team, usually a nurse and dietitian, on a weekly basis, and we're able to take the DIASEND out to their homes to download their meters because they don't have computers. The school's been roped in to support their care during the day, and the team have doggedly persisted in trying to find ways to help Mum and the boys grasp the rudiments of carb counting. It's taken a lot of time and effort, and we're not there yet, but they are now beginning to make some headway. And the youngest particularly is really starting to demonstrate that he's beginning to understand things and asking the right questions. In terms of the audit, this important work isn't going to reflect in our overall figures, but for this family it is making a big difference. Even the older brother's now started taking an interest when the visits take place, and that means he's also being in the opportunity to take on board what's being said. Finally, one other young person I want to share with you is a 16-year-old girl diagnosed again 10 years ago. She had many years of increasingly uncontrolled blood glucose levels, and last year peaked at 139. This was a result of a severe hypo when she was 10, which led to intense fear of hypoglycemia. Psychology and other limited interventions in the past have not really helped her overcome this, and she was testing 15 or more times a day, both day and night, and deliberately running herself very high, not trusting her blood glucose levels to go into the teens at her worst point. She wouldn't trust the advice given by her smart meter, and for several months now, changes in the team have enabled home visits every 7 to 10 days, again shared between the team, and sometimes jointly. Her individual blood glucose targets have still been set very high, but at each visit, tiny changes have been made, and there's been a real effort to focus on not necessarily the numbers, but on building her confidence and the positive behaviour changes with lots of reinforcement and education. At her most recent clinic appointment, her HbA1c has come down to 119, and she's now gradually feeling more confident to test less, and her targets can be reduced little by little. Again, in terms of the audits, this will still show up as a horrendously out-of-range HbA1c, and our team will still continue to sit closer to the bottom than the top of the table. But for her and the many similar individuals that we work with, we are making huge strides. It's a long and slow process, and we know we're not going to work miracles overnight, but with our relatively young team, we feel absolutely positive that we will get there. So my plea is, don't just look at the numbers, look deeper, because there is so much more going on than the audit can tell you.
Thank you very much, Alison, for that. So just to wrap up then, I was obviously a bit nervous coming up to talk today, and I was looking for some inspiration, and I found it in all unusual places, just outside the conference toilets downstairs. I don't know if anyone's seen what's written there, but there's a notice which says, "Success is not final, failure is not fatal, but what counts is the courage to continue." And I think that's what sums up what Alison was just talking about there, about sticking with our young families. In terms of our results, they are starting to improve. So our median HbA1c has come down year on year since 2013. And I think we're now sitting at 69. This isn't in the audit that's just been, but to date, we're at 69 millimoles per mole. And target HbA1cs, our HbA1c less than 58 has increased dramatically, and our HbA1c over 80 has decreased dramatically as well. And we're particularly pleased with that because that reflects some of the work we've talked about today. So now finally, now in 2016, our highs and our lows have crossed over. So we now have more patients, about 21% with HbA1cs less than 58. And we're determined to carry on this trajectory. So finally, I'd like to leave you with a slide where we're an outlier again, but this time for all the right reasons. This is PZ152 in the blue. And next to it is the red, which is the national, all centres in the country. And that is for that, would you recommend our service to a friend or family member, rating out of 10. And we got some really nice feedback, but I included this one, and I just wanted to read this out because I thought that part of the reason for us being here is to really motivate ourselves and to, just as encouraging our young people, we need to encourage ourselves. And I think this comment really encourages us. We feel that the MDT not only work well with each other to make the best of each professional's input, but also closely with us as a family. We are always fully consulted and involved in any decisions. The team offers support and encouragement to the whole family. So I'll leave you with a photograph of us all on a sunny day in sunny Torbay, and thank you for listening.